Good morning, everyone. I'm Dr. Pravija Talapan Manikot. I'm a geriatric psychiatrist working in the Department of Geriatrics and Long-Term Care. I take this opportunity, first and foremost, to thank Dr. Hanadi for her guidance and support in raising awareness about dementia during this World Alzheimer's Month. Thank you, Dr. Hanadi, and thank you to my team for their support in ensuring that this awareness campaign becomes a successful event. So I have no conflict of interest to declare. Learning objectives. By the end of the session, participants will have an understanding about the significance of dementia guideline. They will have a brief overview of the Qatar National Dementia Guideline. So just a little bit of introduction about dementia. I'm sure all of you are already aware. As per the WHO, dementia is an umbrella term for several diseases. It is a syndrome which affects memory and other cognitive abilities like language, spatial abilities, and behavior, which can interfere significantly with a person's day-to-day functioning. As per the Alzheimer's Disease International Report published in 2021, there are approximately around 41 million undiagnosed cases of dementia. So this is a huge number. And when we're looking at the need for prevention, treatment, and the actual service provisions, there is actually a huge gap. And this is disheartening. And a patient, their journey from getting a diagnosis of dementia to end-of-life care, unfortunately, the services are fragmented. If you look at this particular infographic, you can get an idea of the global impact of dementia and that dementia is a public health priority. Before I delve further, I just wanted to take you through a case scenario. These kind of clinical situations does happen in our day-to-day practice. So a 70-year-old lady with some memory concerns for the past 5 to 6 months associated with some sleep disturbances is referred for a memory assessment. And when we look at her instrumental activities of daily living, she is managing with regards to most of those instrumental activities of daily living. Now, she is seen by a physician in Department A and diagnosed with Alzheimer's dementia and started on donepezil, memantine, quetiapine on the same day when she attended the appointment. Then she goes to Department B and she's diagnosed with depression and started on escitalopram. When she goes to Department C, they request her to carry out investigations and memory tests as part of the cognitive assessment. Now imagine the plight of this lady. She's actually seen by 3 different departments who are specializing in memory assessment. And she has come out with a 3 different treatment plan. This shows that there is a huge issue when it comes to assessment, diagnosis, and management of dementia. And it makes us wonder as to why is this happening? So, what are the challenges faced? There are multiple specialties involved in the care, in dementia care. And each specialty, they may have its own approach to diagnosis, treatment, which could then lead to discrepancies in treatment plan. The next thing is the lack of coordination. So the departments or services may not be communicating effectively. So for instance, if a person with dementia gets admitted to an inpatient unit with delirium or other any other condition following a fall or, so on and so forth, when the patient is getting ready for discharge, this particular patient may be referred to another specialized services for memory assessment. So for example, if the patient is under neurology and on discharge may get referred to geriatric medicine or older adult mental services for evaluation of memory. So it would be an process, it would be like, starting the assessment process all over again. So this is another problem. Now, impact on the patient. So imagine a patient with these 3 treatment plans. It would be very confusing and overwhelming, not only for the patient, but their caregivers. It leads to mixed messages and uncertainty regarding the best course of action. Again, there is care fragmentation, which can lead to missed opportunities. So as I was saying earlier, if the person is under one department already where they have assessed her and given a diagnosis and gets referred to another department, and they're then having to go through the whole process again, it is like missed opportunities for early intervention. The treatment may be swapped, it may be changed. So this can then affect the care which the person is receiving. Complexity of symptoms. Some of the symptoms, sometimes when people present, they may be presenting with certain atypical symptoms. And in these circumstances, we need a multidisciplinary approach. Very important aspect is the emotional impact and the caregiver burden. It's huge. And unfortunately, when it comes to dementia, there isn't a cure. So the family members, in a hope that they get the best treatment, they go and visit multiple departments. They even go abroad for treatment, hoping that their near and dear one would be provided with a treatment that would cure them of the condition. So how do we overcome these challenges? Standardization and guidelines. This is where the guidelines play a crucial role in providing a common framework for care across specialties, which can then help us to unify the approaches and ensure that we are practicing evidence-based medicine. And another thing is interdisciplinary communication. Here in Qatar, in public sector, we have electronic health records. So we already have that, the provision where we can see the patient's notes. We can know who is actually seeing the patient and what is the treatment plan from each of the different specialties. So this can help us in shared decision making. And this will ensure that we are providing a good quality care to our patient. Another significant area which we need to overcome is training and education. Healthcare professionals from different specialties, should receive training in dementia care, and there should be that interdisciplinary collaboration, which could then bridge the gap and promote a cohesive approach to care. Now, going to dementia guidelines, the significance. What is the significance of dementia guideline? It kind of enables us to ensure there is consistency and standardization. So there is a standardized framework for dementia care and management. And this helps us to ensure that there is a consistency when it is looking at be it diagnosis, treatment, care practices across healthcare sectors. So not only public sector, but private care facility as well. And it also helps in improving the quality of care, because we would be, the guidelines promote evidence-based practices, so which leads to an improvement in the quality of care. And it provides us with the best available knowledge and strategies for dementia care. And the guidelines also includes recommendation of how we can raise awareness about dementia, which can then indirectly help us in reducing stigma and promote early detection and diagnosis. It also provides information regarding how we can support the caregivers and families. And it reduces the variability in the care. It helps, it ensures that there is a more consistent approach to care, and also addresses the ethical and legal standards, ensures that we are maintaining confidentiality, dignity, privacy of patients with dementia. Dementia guidelines, they provide a foundation for ongoing research and innovation. It encourages the development of new treatments, interventions, and care models. And these guidelines not only has a local impact, but also a global impact as well. And we can actually tailor these guidelines to meet the specific needs. For example, we have the Qatar National Dementia Guideline, which meets the needs of the local population. So we have now covered the significance of the dementia guideline. Moving on to national clinical guidelines, dementia in Qatar. Objective and purpose of the guideline. The objective of the guideline is to define appropriate diagnosis and management of dementia. And the purpose is to improve the appropriate prescribing and referral of patients presenting to any provider organization in Qatar. And this guideline is intended to be used primarily by healthcare professionals. It could be used in primary care settings. It could be used in private care settings and outpatient care settings. So when you look at this guideline, it is described in very detail various pathways looking at dementia diagnosis and management. I will quickly go through the key recommendations of the guideline. So, for instance, when a person presents with memory concerns to, for instance, a primary care physician, it is important that we look at the history to establish the probability of dementia diagnosis. When did it start? How did it start? Has there been a deterioration? And if you're looking at an initial examination, we have to carry out a physical examination and a cognitive testing. So in primary care, it would be a very quick, short cognitive tool which could be used to as part of the evaluation of cognition. And a set of laboratory tests can be ordered to exclude any reversible causes. And once all these are completed, the person can then be referred to specialist care for further evaluation, and where the person will be seen by specialist physicians who have experience of working in memory services. So if dementia is suspected, or even MCI, mild cognitive impairment, is suspected, good history taking is important, along with collateral history, physical examination, and cognitive testing is carried out. The cognitive testing might be slightly more detailed than what the person would have had done in the primary care sector. And along with this, it is very important that a functional assessment is carried out of the basic activities of daily living and also instrumental activities of daily living by occupational therapists. We have to ensure that any caregiver burden is identified at an earlier stage so that they get the right kind of support. We can request for specialist investigations like neuroimaging as part of the assessment. When it comes to diagnosis, we can use a diagnostic criteria for diagnosis of MCI or dementia. DSM-5 is a criteria which could be used, or ICD-10, ICD-11 could be used. The initial diagnosis of dementia should not be made while the patient is in delirious state. So, for example, a person is admitted to hospital and the person is in delirium. And if the family says, okay, even prior to getting admitted to hospital with this acute confusion, they have noticed some memory problems when the person was at home, it is very important that the physician who is looking after that particular patient ensures that the person is referred to appropriate services on discharge from hospital so that they can be evaluated when they are settled in the community. So it is not recommended that a person with delirium, whilst they're an inpatient, is given an initial diagnosis of dementia. You can have patients who already has the diagnosis of dementia, then getting admitted with delirium. And before we give a diagnosis of dementia, we have to ensure all the reversible causes of cognitive impairment is looked into and ruled out. There may be certain medications which may contribute to cognitive decline. So we have to ensure that there is a thorough evaluation which takes place to ensure that all these reversible causes have been ruled out. And the most important thing is when a person is given a diagnosis or we're looking at giving a diagnosis of dementia, it is important that we have a post-diagnostic, it is made very clear that we have a meeting with the patient, and on seeking consent with the patient, if they have capacity to make consent regarding the treatment and management plan, get the family members involved and discuss a diagnosis and provide them with the post-diagnostic support. And we have to ensure that the patients are provided with person-centered care. We look at their needs, their, the dignity, the privacy. We have to ensure what their views are, and they should be part of the decision-making process along with their family members. If you look at non-pharmacological management, we can offer a range of non-pharmacological management options. If a person needs psychological support, they should be provided with psychological support. They should be provided with the educations with regards to the practical measures to ensure that the well-being of the person with dementia and their caregivers are addressed. In Rumeila Hospital, we have cognitive stimulation therapy, which are provided to persons with mild to moderate dementia. Pharmacological management of dementia, it is very important that, if you're initiating any treatment and we're explaining the treatment to the person with regards to a dementia diagnosis, we give all the information to the person and their family members with regards to these medication. There is no cure at the moment. There is lots of research going into finding out if we can look at various different treatment options. But at the moment, we look at acetylcholinesterase inhibitors or memantine, and it should only be started at the advice of the clinician who has the necessary skills and knowledge to do so. And in vascular dementia, if you're looking at prescribing acetylcholinesterase, maybe a mixed type of dementia, that they have a component of vascular dementia plus Alzheimer's dementia, or it could be that there's a component of Lewy body dementia and so on. If a person with dementia is presenting with depression, so they should be, psychological treatment should be considered in these circumstances. If someone presents with sleep disturbances, we have to ensure that there are no other underlying causes of sleep disturbance, usually we do come across in our clinics like obstructive sleep apneas, some patients when they have like heart failures and so on. So we have to ensure that other physical health causes which may be contributing to sleep disturbance is looked into. Hypnotics, we have to be very cautious when we are prescribing because it can increase the risk of falls. Treatment of agitation, aggression, distress, and psychosis. So when we are prescribing antipsychotics, especially in a person living with dementia, we have to be very cautious because it can increase the risk of stroke and mortality. And antipsychotics should only be considered in situations where the person is presenting with psychotic symptoms, or they're presenting with severe behavioral and psychological symptoms, which is posing risk to that particular person and to others. And it is very important that we reassess the patient every 6 weeks and to check whether we need to continue these antipsychotic medication or not. It is equally important that we look at primary and secondary prevention of dementia. So dementia risk reduction plays a huge role, and it can reduce the risk for up to 40%. Last but not the least are caregivers who look after the person with dementia. It is very important that we provide support to these caregivers, and we need to routinely evaluate for caregiver stress, burnout, and so on. So these are the key recommendations of the guideline. So to conclude, dementia is a public health priority. Early diagnosis of dementia is paramount. And dementia clinical guideline, it provides a broad framework for assessment, management, and support for people with dementia. And it provides us with evidence-based practice as well. So dementia does not rob someone of their dignity. It's our reaction to them that does. This is by T. Personal, and she's a dementia specialist. Thank you. Mohammed Salih കഴിഞ്ഞു. Okay, thank you. Thank you. ഒന്ന് കളിക്കാൻ പറ്റുമോ?